All right, good morning, everyone. I'm Ken. I'm a PGY4. I'll be giving my senior lecture today. I want to thank Dr. Allen for helping me out with this presentation. So I'm about to graduate residency, about to be attending in a few weeks. So this is how I feel, really, really excited. Looking back, I can see that all I learned and all the crazy experiences I've had and all the people I've met. But then I'm also, like this, also freaking out. Because every decision that I'm going to be making is going to be on me. The responsibility will be on me. And talking with my co-residents, we all have this common fear of causing harm to our patients by making a mistake. So either maybe doing a medication error or doing a procedure and causing a complication. So no one wants to cause harm for their patient, right? Today, I'm going to be talking about one way that a lot of us may be causing harm without really realizing it, and that's by overtesting, overdiagnosing, and overtreating patients. So these concepts are sort of all interrelated. I'm going to be talking about these concepts and going over some examples. So overtesting, pretty straightforward, means you're doing more testing than is necessary to diagnose your patients. How many of us have ordered tests that we think were unnecessary or over the top? Yeah, everyone, I'm assuming, right? So why do we do it? So here's a couple of reasons that I was able to come up with. So uncertainty, right? So we're working up undifferentiated patients. We have limited time, limited information. Sometimes the patients are very vague with their complaints. They're very unreliable historians sometimes. And you still have to figure out who has a serious pathology and who doesn't. So we end up doing a lot of testing to be sure. The next one is cognitive unloading. So sometimes there's like 20 patients to be picked up and it's very, very busy. So sometimes I'm guilty of this. I just put in some Rainbow Labs about LCM as soon as I can while the stuff is cooking. The third reason is defensive medicine. So I don't want to miss something and get sued. So I don't want to miss the MI, so I'll send troponin. I don't want to miss the PE, so I'll send the D-dimer. So some patients, or sorry, some doctors would feel like, oh, doing more testing will protect you from a lawsuit, which may or may not be true. The next one is patient expectations. So let's say you have a patient who has a minor head trauma. They really, really want to head CT. You don't think it's indicated, but you still do it anyways because the patient really, really wants it. The last reason I came up with was like protocol and sort of institutional culture. So let's say you have a patient that was stroke coded from triage. So you just sort of reflexively put in CT head, CTA, labs, UA, right? Just because that's what we expected to do. So what's the harm of doing all this overtesting? There's something called overdiagnosis. So overdiagnosis is diagnosing a patient with something that was never going to cause them harm to begin with. So this is different than a false positive or a misdiagnosis, right? So an example would be the PSA test. So in the 90s, basically millions and millions of men were screened for prostate cancer with the PSA test, and 15% of them ended up being diagnosed with prostate cancer. But a huge majority of them would never have known to have prostate cancer. They would have died from something completely different, and it would never have affected them. But now you have all these people diagnosed with prostate cancer. They end up getting prostatectomies and getting something called overtreatment, basically. They're getting prostatectomies and radiation, and about 60% of men who get these prostatectomies end up being impotent, and 40% will have chronic urinary leakage. So these are pretty big harms for basically very little benefit for the patient. So I'm going to be going over a bunch of examples that we see and do in the ER. So the first one is PEs. So this is one of the things that we're taught, oh, you cannot miss a PE, you cannot miss a PE. We always think about PEs for anyone who comes in for chest pain or shortness of breath. So back in the day before having CT angios, the first line test is basically a VQ scan. So they look for areas of mismatch where you have good ventilation but poor perfusion, and it gives you a sort of a high, intermediate, or low probability of PE. The problem with this was a huge proportion, so about 35% would be intermediate, which makes it sort of hard to interpret. The gold standard would actually be this pulmonary angiography, which is an invasive procedure. So it's a very, very high threshold to actually do this procedure because you need a whole OR, it's an invasive procedure, there's risk of bleeding. and radiation, and not every hospital has this. But in 1998, the CT angio came out, which we all love, and you could directly visualize the thrombus in the pulmonary arteries, right? And this is very sensitive, very specific. Every hospital has a CAT scanner. It's very easy to do. So we do this a lot nowadays, and we end up diagnosing a lot more PEs since 1998. But this study, which looked at the years before CTAs were available and compared them to years afterwards, and they found this. So if you look at the dotted line, that's 1998, sort of when the CTA became very widely available. The years sort of preceding it, you can see the blue line, which is the incidence of PE, was sort of flat, roughly 60 per 100,000. And then the years after the dot line are sharply increased, right? So roughly 110, 120. So it rose maybe 80%. So it's 80% higher diagnosis of PE since CAT scans were available. But if you look at the red line, which is the mortality, it has not changed. So it was roughly 12 per 100,000 before and afterwards. So no significant change. So what does this indicate? So if there really was a higher incidence of PE, you should see the ratio of the fatal PEs diagnosed compared to the non-fatal diagnosed PEs should be increasing about the same, which is the first case. If all these cases that we're catching were benefiting from that diagnosis, you should actually have a lower case for fatality. So the amount of deaths should go down. But what we have is this third situation where the incidence went up, but the mortality stayed the same. So that tells us all the extra diagnoses that we get are these non-fatal PEs. And basically they're not getting any benefit from us diagnosing with these PEs. So this is from that same study, looking at patients who are hospitalized for PEs and looking at the complications that they're experiencing. So they found significant increase in intracranial hemorrhage, thrombocytopenia, and GI hemorrhage in the years after the CTAs were available. So that's showing that we're diagnosing a lot of patients with PE, we're treating with anticoagulation, but they're getting all these side effects and harms from it, but they're not getting any benefit in being diagnosed or treated. So now we have this patient, we're telling them that PE, so every time they have to get a procedure, and now they're on anticoagulation, that's a big deal, right? So they have to take time off of work to go see their doctor, to have them monitor their anticoagulation. They have to, their insurance may be affected, right? And now they're also labeled as someone who has a history of PE or TPT. So every time they have chest pain or shortness of breath, they go to the ER and they tell the doctor, oh yeah, I've had a PE before. And then they end up getting D-dimered and getting another CAT scan, right? So there's a lot of harms that have been caused by these overdiagnoses. The next example I'm going to talk about is the routine admission chest X-ray. So let's say we have this 30-year-old female, she's otherwise healthy. She came in with flank pain and dysuria and fever and nausea, and you work her up, you find that she has pyelo, you want to admit her for antibiotics and hydration. And just because you're admitting her, you get an admission chest X-ray. And then radiology calls you and they tell you, oh, she has a 2-millimeter pulmonary nodule. You should get a CAT scan in 12 months. So is there any benefit in getting these routine chest X-rays for no good reason? So there's a couple studies that were done looking at this. So this one was done in Brooklyn Hospital Center. So they looked at all admissions within a 4-month period. So there were 229 admissions, and 126 of them, they determined those X-rays that were done for pre-admission were basically unnecessary. There's no findings based on their history or their exam that indicated they need a chest X-ray. And of these 126 chest X-rays, only 3.8% had any finding at all that changed management. This other study looked at 675 consecutive admissions at a hospital. And out of all the admissions, indicator or not, there were 545 chest X-rays that were done. They found that 25% of them had a positive contribution, but for a majority of them, they had either a negative contribution or no change in management. And they specifically found that if there was an indication based on history or exam, it had a significantly higher odds ratio of making a positive contribution. So odds ratio of 10. And if there was no clinical indication, only 3.6% had a positive contribution. So that means for all these routine admission chest x-rays without any sort of real indication, 96% of them had basically harm or no change in management. And so what does the ACR guideline say? So according to them, routine chest radiograph with no clinical concern on basis of history exam is usually inappropriate. So if PIC or someone wants a routine chest x-ray, you could point them to this. So what's the harm of getting these routine chest x-rays? So one, it delays the admission, right? So that's another patient that the transporter has to wheel to x-ray and wheel them back, and delays your other patients who need imaging. It causes crowding in the ER, and that has been shown to be associated with increased mortality in the ER. There's the incidentalomas, right? So there's a lot of times you find these pulmonary nodules, and then that's, that they have to get followed up, right? And that puts you, the ED doctor, at risk, right? Because now you have to, now it's your responsibility for these patients to get follow-up, essentially. There's radiation associated with it and monetary costs associated with it, right? So a lot of our patients are uninsured, so a chest x-ray can cost like what, $150, and that's could be a lot of money for someone who has no insurance. Which brings me to my next topic, which is incidentalomas. So this study looking at chest x-rays done for patients with acute cough, about 20% of them have incidental findings on chest x-ray. This study looked at PE studies. So they found that if you're looking for a PE and you get a CTA, you get a PE in about 13% of your CTAs, but you also have a 13.1% chance of finding an incidental finding. So you're just as likely to catch a PE as you are to get an incidental finding. And they also found that ultimately, after working up these patients, 88% of them end up being insignificant findings. This one was looking at CT abdomen from the ER. So out of 1,155 CT abdomens, they had 700 patients with incidental findings. And they found that, so the initial CT abdomens had about 15,000 RVUs worth of work associated with them, but then subsequently all the incidental findings and resulting other imagings that needed to be done resulted in another 1,600 RVUs, right? So that's more reads our radiologists have to do that delays reads that we actually care about, and it causes more work and more bloat and more money for everyone. This study looked at CT scans done in trauma patients. So 40% of CAT scans done for trauma patients ended up having incidental findings, and they also found in the study that that results in a longer length of stay for patients who had incidental findings by about 2 days. So I feel like every other CAT scan I do, I get a call about a adrenal incidentaloma. So this is the workup that's required for adrenal incidentaloma. So the patient has to take time off. They have to go to their PCP or endocrinologist. They have to get a bunch of these hormone studies, right? Dexamethasone suppression tests and 24-hour urine collections and repeat CAT scans and MRIs and subsequently possibly surgeries and biopsies. So the prevalence of having a hormonally active adrenal incidentaloma was very, very low to begin with. And most of them are usually just subclinical Cushing syndrome. So basically very low clinical importance. And the prevalence of malignancy is also is much lower, even lower than that, less than 5%. So you have a low prevalence and a very low pre-test probability to begin with. So a lot of these will end up being more likely to be a false positive than a true positive. And you're subjecting them to all these tests and even possibly biopsy and all the harms that can come along with that. And this study actually suggests that the recommended CAT scan that we do for following up these incidentalomas, the radiation from that CAT scan is more likely to cause a fatal cancer than you are to actually catch a malignancy from an adrenal malignancy, basically, which is pretty surprising. My next example is stress testing in ACS in the low risk patients. So in this example, we have a 50-year-old guy. He's coming in with chest pain. He has an unconcerning story. You want to work him up for ACS. You do your troponin, your EKG. They're both negative. You repeat a troponin EKG in a couple hours. They're still negative. So you feel like he's low risk for ACS. You decide to discharge him, and you tell him, okay, follow up with your cardiologist in a couple days, so they can do a stress test for you. And previously, this is sort of what the AHA ACC recommended. So any patient who came to the ER for ACS workup and had negative troponins and negative EKG, they recommended a stress test within 72 hours of discharge from the ER, regardless of if they're high risk or low risk. But there's so many studies that came out showing the limitations of these stress tests. So for example, this one was a prospective study that looked at about 4,000 patients who were in the chest pain obs units. About 11% of them had positive stress tests, and they capped a bunch of those patients, and only 50% of them had actual CAD on their caps, right? So a lot of patients got unnecessary caps. There's a lot of these studies came out. This one had 657 patients, 14% had positive stress tests, 41 were capped, and only 4 had positive CAD on their caps. This one had like 220 patients, 6 had positive stress tests, 4 were capped, and no one had CAD, right? This one, no, there's a lot of these studies, so I'm not going to go through all of them. So this one, there's also this one who had like 20 true positive versus 9 false positives. This study had 1,100 patients with 5% positive stress tests, 69 that were capped were negative. They found that also the costs for patients with positive stress tests are significantly higher than the ones with negative stress tests, right? Because they get subsequently more testing and more workup and cath and procedures. So $7,000 versus $1,500. And it also increased their inpatient length of stay as well. This study was done from the Kaiser system. So they looked at 200,000 patients who went to the ER for chest pain, and they grouped them in groups of how intensely they were referred for stress testing. And they found that patients who were had higher intensity referral for stress testing actually had higher incidences of MACE, because they ended up getting more revascularization, and they counted that as MACE. But if you took out the patients who got revascularized, the MACE was the same, and the mortality was the same in high or low or intermediate referrals. So basically, stress testing doesn't seem to really help, and it may cause a lot of harm. And so actually, the AHA actually changed their recommendations recently, like a year ago. So now they're saying there's no evidence that stress testing in low-risk patients improve outcomes. So great. But let's say our patient from the vignette gets a stress test and it's positive, and he gets cath, and he was a true positive. He actually has CAD, and we put a stent in, and we helped him, right? That's good, despite the 10 other people who got cath and had nothing, right? But actually, there's this Cochrane review that came out comparing patients who had a very invasive path. So every patient that got admitted got cath, and if they needed a stent, they put in a stent, versus the more conservative group, where they initially did only medical management and only cathed them if they had persistent signs of ischemia. Their study had this Cochrane review included 8 RCTs, total of almost 9,000 patients, 4,500 in the invasive strategy and roughly 4,500 in the conservative strategy. And what they found at 12 months was that there was no significant change in mortality and no significant change in death or non-fatal MIs. So there's not that much benefit. But there was significantly increased risk of bleeding and significantly increased risk of procedural related MI. So it sounds like you're actually more likely to get a procedurally related MI than you are to have a decrease in your risk of non-fatal MI after a stent. What they did find was there was decrease in refractory angina and decrease in rehospitalization. But you should also take this with a grain of salt because these studies were not blinded. So if you had a patient who came back a month later with chest pain and they were in the group that had a cath that was negative, you would just say, oh, it's not angina, I'm not gonna admit him, just discharge him. So the conservative group would end up getting more admissions, right? Because they basically had they never got cath, right? So those patients more likely to be admitted. So take this with a grain of salt. My next example is routine labs in our medical clearances for our psych patients. So in this case, let's say we have a 25-year-old male with schizophrenia, bipolar. His mom brings him in because he's becoming more disorganized and more paranoid, and he's having worsening hallucinations. He's been lost to follow-up for the past year, and maybe he's been off his meds for a while. So you consult psychiatry. They're saying, oh, send him to CPEP. You talk to the internists. Oh, they want labs, they want EKG, they want a UTOX. But he's paranoid. He's not cooperative. He doesn't want to get the labs done. So now you have to sedate him to facilitate his workup. And is this some? So what does ACEP say about this? So this is based on this is ACEP stance. So they say do not routinely order laboratory testing on patients with acute psychiatric symptoms. Use medical history, previous psychiatric diagnosis, and physician examination to guide your testing. They also say something similar about CAT scans as well of the brain. So if there's nuance of psychosis without focal neurologic deficits, no, not necessary to CAT scan them. This is from the American Academy of Pediatrics, and this is their stance on children and adolescents with acute mental or behavioral health problems. So they're saying, okay, the current body of literature supports focused medical assessments for ED psychiatric patients, where laboratory and radiologic testing is obtained on the basis of their history and physical exam. Routine testing is usually low yield and costly and unlikely to be of any value. What about the American Psychiatric Association? So they're saying the decision to do laboratory studies and other clinical tests such as EKGs and EEGs should be based on the likelihood that the test will result in in altering diagnostic or treatment related decision making. So it seems like everyone's on board, but yet we're still sort of forced to do these routine psych labs. So what's the evidence for this? So this study looked at 502 consecutive psych ER visits, where this is in a hospital where they required everyone to get a CBC, a comprehensive, a TSH, a T4, a B12, a folate, a UTOX, and a UPreg, or if they're female. So they looked at 502 consecutive charts, and only one patient had any abnormality that required any sort of intervention. And that particular patient was tachycardic and febrile and had a high anion gap and a high glucose level. So it was sort of obvious based on exam that they would need labs to begin with. This study was done in California. So they had 375 patients with psych patients with labs that were done. So about 15% of them ended up having abnormal labs. So a majority of the patients who ended up having abnormal labs had something on their history or exam that would have indicated that you needed a workup anyways. And only 4 of the abnormal patients with abnormal labs had anything. Sorry, only 4 of the patients who had abnormal labs had a completely benign history of physical. But all those labs were just abnormal UAs, and they had no change on their disposition. So let's see, this study came out last year in Annals. So this looked at Tylenol and aspirin levels done at the VA. So over a 10-year period, they had 17,000 Tylenol and aspirin levels sent for psych patients. Literally 0 cases of toxicity were found. So I'm wondering, has anyone ever actually seen like from these screening labs, found a positive Tylenol or aspirin level without a history of someone actually ingesting something? Yeah, I haven't either. So yeah, so this study sort of backs it up as well. So this one is looking at specifically peds psych ER visits. So at this hospital, they had 1,000 visits with 871 patients having lab tests done, resulting in 13,000 lab results, basically. Only 7 of the 13,000 had any abnormal findings that resulted in in any sort of disposition change. And they also found that patients who had labs done compared to the ones who did not have labs done had almost 2 hours longer length of stay in the ER. The study looked at chest x-rays, so in SEC patients, so 332 patients were seen and 200 of them had chest x-rays done. So 95% of them basically were either normal or had irrelevant sort of findings, and 5 of them had abnormalities that were sort of known already, so it changed nothing in their management. So literally in the study, 0 out of the 200 had any changes done from the chest x-rays. And there's a bunch of other examples that I'm not going to go into because this lecture will go on forever, but there's imaging for non-traumatic back pain. There's head CTs for syncope in patients with without any head trauma or abnormal neuro findings. There's some studies that show x-rays for joints above and below the affected joint in a low risk trauma is also unnecessary. Routine pre-op labs, CT scans for nephrolithiasis, et cetera, et cetera. There's a lot of stuff that you can look into if you guys are curious. In summary, more testing is not always better. Overtesting can lead to overdiagnosis and overtreatment. Waste time, wastes money, causes unnecessary harm to our patients, causes ED crowding, increases length of stay, and only order tests if there's clinical indication from history or exam. So these are my sources. Any questions?